Elbasvir-grazoprevir, its place in today's current treatment algorithm. The speakers today are Andrew Muir, Chief of GI at Duke University School of Medicine, and Ira Jacobson, Chairman of Medicine at the Mount Sinai Beth Israel Icahn School of Medicine at Mount Sinai. Just parenthetically, the HCV Special Interest Group is made up of 5 members. Nora Teralt is the chair. Myself, Jordan Feld, Nancy Rao, and Andrew Muir are all members. The SIG benefits include presentations at the annual meetings, early morning workshops, abstract reviews, webinars, and networking. If you're interested, you may join the AASLD SIG online at the website shown. Just to give you a little bit about our webinar structure, it's 1 hour in length, 2 presentations. A question and answer period will occur at the end of the presentations, but you may enter your questions in the chat line whenever you wish. There's a chat box at the bottom of your right-hand corner of your screen. With that, we'll start with our first speaker Andrew Muir, on Elbasvir-grazoprevir for treatment-naive and treatment-experienced patients.
Thank you, Paul. It's great to be with you all, and I appreciate the opportunity from AASLD. And my job is to kind of take you through how we're going to use this great new regimen of Elbasvir-grazoprevir for naive and treatment-experienced patients, and I'm going to particularly focus on the non-cirrhotic group. So these are my disclosures from some of the relevant trials and advisory boards that we do. And I also wanted to just give some background on the regimen, just briefly. So this is a combination of Elbasvir, which is an NS5A inhibitor, along with grazoprevir, which is a protease inhibitor. Its FDA indications are in genotypes 1 or 4. It's dosed once daily as a fixed-dose combination, with or without food. Its metabolism is primarily by CYP3A, and so we'll later talk about some drug-drug interactions. Its excretion is more than 90% in feces and less than 1% in urine, which is why Ira later will be talking to us about its role in patients with chronic kidney disease. There are some contraindications to consider, including in Child-Pugh class B and C patients, and also with certain drugs, particularly with concomitant use of OATB 1B, 1,3 inhibitors, strong inducers of CYP3A, and as well as efavirenz. So I've put here the FDA what they came up with as far as the indications for grazoprevir, Elbasvir. And starting off at the top, we talk about genotype 1A patients, and you see that the status of treatment-naive or PEG, interferon, ribavirin experienced is similar. And right away, we get into this issue about if there are NS5A baseline polymorphisms or not. And that does indicate whether we have ribavirin in the mix and the duration. And just to highlight there, if these polymorphisms are present, then it's recommended that ribavirin be added to the regimen, and the duration is extended to 16 weeks. On the next line down, if you see with the genotype 1B patients that there's not the same issue as far as those polymorphisms, and those patients do not need ribavirin and get 12 weeks of treatment. Now, coming down is in the next line of the table there is if the patients were previously treated with a protease inhibitor along with PEG interferon alpha and ribavirin. And you see that all those patients, whether 1A, 1B, are recommended to receive ribavirin and its 12-week duration. And notice that the polymorphism recommendation is not in there, and we'll talk about that more later. This is also recommended for genotypes 4, and treatment-naive patients are recommended for 12 weeks of treatment without ribavirin, and the PEG interferon ribavirin experienced patients are recommended to receive ribavirin and get 16 weeks. So let's talk a little bit about some of the data that guided this. This is a large, robust development program, and the CEDGE study included treatment-naive portion, which was genotypes 1, 4, and 6, and 22% of the patients had cirrhosis. This is a well-done randomized controlled large trial with a 3-to-1 ratio of immediate to deferred treatment, so we can understand some about adverse events. And all patients received the fixed-dose combination of Elbasvir-grazoprevir, and the duration was 12 weeks. And these are the overall data by genotype and subtype. So you see that, again, large group, in 1A patients it's 92%, or up at 99%, again in a large group of patients for 1B. All 18 patients with genotype 4 achieved SVR12, and 8 of the 10 with genotype 6 achieved SVR12. So let's get into a little bit more about why is there this recommendation for NS5A resistant variant testing at baseline. So, and this is from the manuscript by Dr. Zoism, looking at how it broke out, whether or not you had NS5A variants present. And we see again the 1Bs are there on the left with 99% SPR12. The 1As it's at 92%, but you break it down about whether you were 1A with no NS5A RAVs. You see there we're at 99%. And you notice on the far right, there's 19. So think a little bit about the denominator. 19 of those patients, and 11 of them achieved SVR. So we're down there at 58%, and it appeared to make a difference. I put here the FDA analysis of baseline resistance. So this is looking at a number of the studies from the development program and trying to understand the meaning of this NS5A resistance in these genotype 1A patients. And what they saw that there were these polymorphisms that did appear to be associated with reduced efficacy. And they were at positions M28, Q30, L31, or Y93. And the prevalence of these variants, when you're thinking about overall in your population, was 11% for the development program. So 62 out of 561 patients. And down there in the table, you see that if there were baseline polymorphisms present, the patients received 12 weeks of the Elbasvir-grazoprevir without ribavirin, their SVR rate was 70%. And you see over there, when there were patients that received the extended duration with ribavirin were at 100%. Granted, it's 6 out of 6 people. But I think this lower response rate without ribavirin for the shorter duration, the concern there is it's what's led to this recommendation for the testing and the change in therapy. At the bottom of the table, you see there's no polymorphisms. Again, the patients do great with that 12-week regimen. And I just wanted to go a little bit more into some of the other data from the program. Again, it's a very robust development program. This is the treatment experience patients from the C-EDGE program. These are genotypes 1 and 4. These patients failed peg interferon and ribavirin. And 34% cirrhosis, so reflective of our practice in a nice randomized controlled trial. And this study looked at 16 weeks versus 12 weeks and looked at with and without ribavirin. And if you look over on the right, you see that, again, the 1B patients do great regardless of the duration and the presence of ribavirin. But on the left, the 1A patients, as we add in ribavirin and as we extend the duration is where we see the higher response rates. And that's felt to be reflective of some of this issue with resistance. Another very interesting study is the C-Salvage study, and this is for the patients who are protease inhibitor failures. So again, these are people who genotype 1, and they failed previously with peg interferon ribavirin and either boceprevir, telaprevir, or cimipravir. 43% of these patients had cirrhosis, and 46% of them had baseline NS3 variants, but that's NS3 if you notice. So again, this is an open-label, single-arm study, and the patients received Elbasvir-grazoprevir and ribavirin, so everyone received ribavirin for 12 weeks. And you see here that we only have 3 failures. It's 76 out of 79, or 96% of the patients achieving SVR12. So a very successful outcome here for the group. I also want to reflect a little bit on the data for genotype 4. I've tried to put together a table here of the different studies that looked at genotype 4 patients. I have there at the top the C-EDGE group we already talked about. There were genotype 4 patients in the co-infection study as well. They did very well. C-SCAPE was a study that looked at a number of different genotypes, and again, the genotype 4 patients did well. And at the bottom is the breakdown from the C-EDGE treatment experience trial to get a sense of them. And then I highlighted kind of what the FDA recommended just to show you where the data from where that came from. But you see that with those treatment experienced patients, they did recommend a longer duration and the addition of ribavirin. So now I want to shift gears a little bit and just to talk a little bit more about the regimen so everybody's comfortable with it. This is another time that by whatever resource you use, you need to be comfortable with examining drug-drug interactions, whether it's one of the online tools or the package inserts. But CYP3A inducers, you'll see lower levels of Elbasvir-grazoprevir. CYP3A inhibitors, you'll see increased levels. And the OATB1B1.3 inhibitors, you'll see increased grazoprevir, and therefore you can have increased ALT. So I'm not going to read this entire table to you, but again, just to give you a sense of some of the common drugs that we need to consider. That would include the anticonvulsants of phenytoin, carbamazepine, rifampin's on there, St. John's wort, and the HIV antivirals, particularly efavirenz is listed there as contraindicated as well. For our transplant patients, cyclosporin is contraindicated with increased ALT, and it's a recommendation to use with caution with tacrolimus. Down there at the bottom, the statins, we see that we can get increased statin levels there, and so reduced doses are recommended, but no dose adjustment is there for pitavastatin or pravastatin. And I think one of the other important things to recommend when thinking about this regimen compared to some of the others that are available is there are no significant interactions with acid-reducing agents, proton pump inhibitors, H2 blockers, and acids, and that can be important for some of our patients. Also, no interactions for buprenorphine, naloxone, digoxone, methadone, oral contraceptives, and thankfully ribavirin. I want to say a little bit about the adverse event profile as well. In general, again, I think this was a very robust development program and helpful in that regard. In the ribavirin-free regimens, we did see slight increases in fatigue, headache, and nausea, but I would say generally extremely well tolerated. When ribavirin is included, we did see anemia and headache, as would be expected. The discontinuations for adverse events were 1%, and a key point there being was similar to placebo, so we felt very confident in that regard. One thing we do have to watch for is ALT elevations. So ALT more than 5 times the upper limit of normal was reported in 12 out of 1,599 patients. So, and the things that were noted here, this was at week 8 or later. It was typically asymptomatic, and most resolved without discontinuation or intervention. In the analysis there was a pretty increased rate at 2% there in women, Asians, and age greater than 65. An important thing that this was studied well in patients with cirrhosis and was not clearly increased in Child-Pugh A cirrhosis. So in the package insert, it's recommended that if you're giving the patient a 12-week regimen, that you check the liver test at baseline and then at week 8. If it's a 16-week regimen, then check at baseline, week 8, and week 12. And consider discontinuing it if the ALT is greater than 10 times normal. And obviously, we're going to watch these patients very closely, and you would consider discontinuing if any concerns, including conjugated bilirubin increase, alcohol, phosphorylated are out. So I did sort of want to bring this all together and think about where does this fit in with what we have. And so I put together this table of our genotype 1A patients without cirrhosis according to the AASLD IDSA guidance that we have right now. And you'll notice if the top row there is that those patients with no prior treatment or the PEG ribavirin failures. And you see, this fits in with this group of regimens that are all recommended. And with the caveat here that there is the recommendation for the variant testing for Elbasvir-grazoprevir, and you would extend to 16 weeks with ribavirin if those are present. If they're not present, which is going to be the case for many of the patients, then we're talking about a ribavirin-free regimen for the 1A patients. Down to the bottom is where the PI failure group has come in, and notice that the AASLD IDSA guidance does actually recommend the resistance testing and the adjustment, which is not the same as it actually was in the package insert, but was the ultimate recommendation for that group. Following along the line that if it mattered in the other groups, it probably also matters in the patients who failed a first-generation protease inhibitor. And here is for the patients who are genotype 1B without cirrhosis. I think we've seen repeatedly that this group of patients does extremely well. They have a number of ribavirin-free regimens here as well. And it's really only we get down to the bottom with the PEG ribavirin and PI failure group do we see some split about where these have been studied. But grazoprevir Elbasvir fits in well there and is a 12-week regimen with the addition of ribavirin for those patients. I also just put in where we sit with the genotype 4 guidance at this point. And you see that down the line we have three regimens that are now recommended: ladibasvir, sofosbuvir, paritaprevir boosted by ritonavir with embedisvir, and we have Elbasvir-grazoprevir that's added into that group as well. So these patients also thankfully have a number of choices at this point, which is important to have. So where do I see Elbasvir-grazoprevir fitting in? So we have a ribavirin-free option for 1A patients without the baseline NS5A RABs. I'd also add that for those patients who do have that, we also know that those patients are well served by this regimen with ribavirin. We have another very effective regimen for genotypes 1B, 4, and the PI failures, so we have options there, and that's important. Dr. Jacobson is going to go into much more detail about this as an excellent choice for patients with kidney disease. And also, I think for those patients that do have that severe reflux disease or require acid suppression, that this is a regimen that they can feel very good about and not have concerns that there may be interactions there that it could impact the treatment. But all in all, I think this is great to see. It's exciting to have another regimen, another impressive regimen that's added to our armamentarium as we try to help our patients with hepatitis C. And with that, I'm going to turn it back over to Dr. Pockros.
Thank you very much, Andrew. It was an excellent review. And Ira, you want to go into special populations with cirrhosis and renal failure?
Yes, Paul, of course, and thank you for including me in this nice program. I will focus on two populations of great interest about whom we have a lot of data, those with cirrhosis and those with renal failure. This is by far the largest population of patients with renal failure studied thus far in the pivotal program or any other trial for that matter, and we'll touch on that a little bit later. Why focus on cirrhosis, given the advances that we've made in the field? Well, let's remember that historically there were much lower response rates to interferon-based therapy with cirrhosis and higher risks of side effects. We still don't understand the mechanisms for lower efficacy in cirrhosis with interferon-based therapy, and to the extent it still remains a little bit of a challenge with some regimens, one can still continue to speculate about why this should be. There are still a few challenges with DAA regimens, and we've learned that with a number of the regimens already approved, that either a longer duration of therapy and or ribavirin are needed with cirrhotics who either have genotype 1A or genotype 1A and 1B, and sometimes it depends on the treatment status of the patient, that is with regard to whether they're treatment naive or treatment experienced, in particular with interferon-based therapy in the past. Let's remember that protease inhibitors in general are categorized in variable cases as either not recommended or contraindicated in Child-Pugh B or C patients. It's a little different for the different protease inhibitors. I would point out that grazoprevir, along with Elbasvir, grazoprevir of course being the protease inhibitor, was studied in 30 patients, and this presentation was at EASL last spring, in a study called SEASALT, which did show both efficacy and safety of grazoprevir given at half dose because of the modest accumulation that can occur in cirrhotics, along with Elbasvir, but it was ultimately decided not to pursue the regimen in this population of patients with decompensated cirrhotics. Now I'm going to go through 4 slides that very quickly contrast the efficacy rates in non-cirrhotics versus cirrhotics, and Andy has already touched on a couple of these studies. You'll see them again in this comparative context, and the overarching theme here is the similarity of the SVR rates with the same exact regimen when given to cirrhotics versus non-cirrhotics. So here we have the aforementioned C-EDGE treatment-naive regimen in genotype 1 mostly, but a few 4s and very few genotype 6 patients given dual therapy without ribavirin for 12 weeks. The numbers speak for themselves, 97% SVR in cirrhotics, 94% in non-cirrhotics. So clearly no disadvantage in this robust data set for cirrhotics. Adverse events were similar between the two populations, and 4 patients, including 1 cirrhotic, had late ALT elevations consisting of ALT elevations to 5 times the upper limit of normal, but without concomitant elevations in bilirubin. The C-EDGE treatment experienced study, which Andy has also shown you, largely again showed similarities with one of 4 regimens, or various of 4 regimens, as you see along the x-axis here, either including ribavirin or not including it, and comparing 12 to 16 weeks, similar between cirrhotics and non-cirrhotics, with notably a 100% SVR rate at the right end of the slide with 16 weeks with ribavirin in the cirrhotic population. Now, as Andy has pointed out, the driver of virologic failure in this study consisted almost entirely of the presence of baseline high-level resistance-associated variants, not the status of the liver or any other baseline factors, and we'll be returning to this theme as we go along. The C-SALVAGE study evaluated grazoprevir, Elbasvir, and ribavirin for genotype 1 patients who failed peg interferon and ribavirin previously with a protease inhibitor, a scenario that one might speculate could be problematic because of the likely existence of protease inhibitor-resistant variants in a substantial number of these protease-exposed patients. And yet the SVR rates were, as Andy showed you, very high and certainly competitive in cirrhotics versus the overall population, or obviously non-cirrhotics when you make that comparison. And finally, the C-EDGE HIV co-infection study with dual therapy for 12 weeks, a 100% rate of SVR in 35 cirrhotic patients. Now, I'd like to show you the results of a study that I was privileged to present at AASLD a few months ago. of an integrated analysis of 402 compensated cirrhotic patients with HCV genotypes 1, 4, or 6 treated with Elbasvir and grazoprevir. And if you'll forgive me, the graphics are going to change a little bit because I'm taking the liberty of showing all of you the slides that were actually presented in the plenary presentation at the meeting. And so here we have our 402 patients in this integrated analysis, of whom 169 were treatment naive, given 12 weeks of therapy, and 233 were treatment experienced, given either 12, 16, or 18 weeks of therapy across 6 different studies. To remind you, the C-Worthy program, which contained both naive and experienced patients, was a phase 2 program. C-Surfer was the large study in patients with renal failure that I'm going to spend considerable time talking about in a few minutes. You've already heard about the C-Edge treatment naive and treatment experienced studies, as well as C-Salvage and the prior protease inhibitor failures and the co-infection studies. So these 402 patients are pooled across these studies and represent the large collection of compensated cirrhotics in these studies. Cirrhosis was defined variably, as you see here, either by liver biopsy or a FibroScan over 12.5 kilopascals, or by a combination of APRI and FibroTest, the latter over 0.75. The enrollment excluded patients with particularly high ALT or AST elevations, low albumins less than 3, platelets less than 50, INRs over 1.7. And we studied, as I indicated before, either 12 weeks of once-daily therapy with or without ribavirin, or 16 weeks of once-daily therapy with or without ribavirin. And I'll be showing you results conducted by both full analysis or modified analysis, or modified full analysis to be precise, which will exclude patients with non-virologic failure. The demographics, I would bring it to the middle of the slide immediately and show you that somewhat over half the patients had genotype 1A, most of the rest 1B, with a collection of 23 genotype 4 patients and a few genotype 6 patients. 10% were co-infected and 42% were treatment naive. 58% were prior treatment failures, and I'll be saying a word about the 49 or 12% relapsers shortly because they do seem to be a little bit different than the non-responders, as I'll show you. When we go to the next slide, we just want to look at the treatment-naive patients initially, shown in blue, and we can readily see that with 12 weeks of therapy in these treatment-naive patients, that ribavirin doesn't appear to be necessary. Indeed, probably just because of happenstance, the non-ribavirin group had a higher SVR rate at 98% compared to 90% in the ribavirin group. If you look at the modified full analysis set at the bottom and leave out the non-virologic failures, you can see that if you factor in the relapse rates, that difference holds up. And certainly you can see the 98.5% SVR12 rate in the patients who didn't get ribavirin and got only 12 weeks. So this would certainly imply strongly that in these cirrhotic patients that 12 weeks of therapy without ribavirin is a satisfactory regimen. If we look some more at these treatment-naive patients and go back to the overall SVR rate of 98%, you can see it on the left, 96% proceeding to the right, and the 1As, 100% in the 1Bs with a few other genotype 1s that I guess couldn't be subtyped, and 6 out of 6 or 100% of the genotype 4s. If we ask ourselves whether there might have been a difference based on platelet count, that is reflecting presumably the degree of cirrhosis or portal hypertension, we don't really see an impact. There were 36 patients with platelet counts between 50 and 100,000, 97% SVR. It didn't matter how you determined the presence or absence of cirrhosis, whether by biopsy, the APRI-FibroTest combination, or FibroScan, and the FibroScan value itself. And I think this is of particular interest in this analysis because we do know now that once you're cirrhotic by FibroScan, the test does go all the way up from 12.5 to 75, and obviously the patients at the higher end are known to be much more advanced and be much more subject to complications of portal hypertension or even liver cancer. So it's reassuring to see the evenness of those gray bars reflecting at the right end of the slide those with very high FibroScan scores. Now, if we go to the treatment-experienced patients, we can see two groups of patients, those who were treated for 12 weeks and those who got 16 or 18 weeks of therapy. The 18-week patients were those in the phase 2 C-Worthy program. And I'm highlighting the two bars that are of interest because these are the two regimens that are out there and available, either the 12-week no ribavirin regimen or the 16-week as it is in the package insert with ribavirin regimen. And we do get the idea that maybe the ideal therapy, it's hard to argue with that number of 100%, is 16 or 18 weeks with ribavirin. We might ask, however, whether there could be identifiers of patients who were treatment experienced but still could be optimally treated for 12 weeks in the absence of ribavirin. And here's where I get back to the relapser theme, where we see that although the number of relapsers is not particularly high here, that of those in the modified full analysis set who got one of the two regimens that we're comparing, 12 weeks no riba versus 16 or 18 weeks with ribavirin, that the SVR rate was in fact 100% in the prior relapsers, and that where the 12 weeks was lacking in optimal efficacy was in the prior non-responders as opposed to the prior relapsers. So I've highlighted at the bottom the theme of this slide, which is that patients with a history of PEG-RIBA non-response benefited from extension of therapy to 16 or 18 weeks with ribavirin, and that relapsers may not require extension of therapy, and this concept has actually been incorporated into the package insert for the product. Now, if we look at SVR by platelet count here, we can compare the blue patients who had low platelet counts versus those whose platelets were higher, and we see the same theme echoing here that we saw in the treatment-naive patients, namely that platelet counts below 100,000 didn't adversely impact SVR in any of the patient subsets or with any of the particular regimens. Now, if we think about safety in the full analysis set here, there was a low incidence, as you might expect in these sorts of studies, of serious SAEs, only one serious drug-related AE, 2 deaths in the 2 ribavirin groups. There was a placebo comparator here taken from the C-EDGE treatment-naive study. And if you go to the bottom, you can see that the 2 deaths consisted of coronary disease and a motor vehicle accident, so we might reasonably infer that these were unrelated to drug. If we look at discontinuations due to an AE, we can also see the causes given at the bottom. And again, these are, I think, reasonably inferred to be unrelated to study drug, but they do include, for the record, lymphoma, uterine bleeding, tachycardia, depression, and portal vein thrombosis/colitis. There was one discontinuation due to a lab AE, which is important to mention. This was a patient who received Elbasvir-grazoprevir without ribavirin, and at the bottom you can see there's information under the 2 asterisks that this was a patient who elevated his or her ALT with a mild eosinophilia, and in fact this patient did not become clinically ill, but was mandated to stop therapy by the terms of the protocol due to the degree of ALT elevation. Systemic side effects were relatively infrequent. There were some that were somewhat common, but none that were serious, like fatigue, headache, and nausea, and a substantial incidence of these in the placebo group, sometimes matching those in the active treatment groups. If we look at laboratory values next, we can see most immediately that it's ribavirin that drives a lot of the incremental side effects when you compare the no riba group to the ribavirin group. We do see a few grade 3 ALT elevations, 1 grade 4 ALT elevation that I've already mentioned, and just a very small number of elevated bilirubins, but no patient met the criteria for Hy's law. And in fact, the bilirubin elevations were dissociated from the ALT elevations in the program in general. So in conclusion, in compensated cirrhotics, the regimen of grazoprevir and Elbasvir is highly effective. In treatment-naive patients, given 12 weeks of therapy without ribavirin of this dual 1-tablet combination therapy, SVR12 in genotypes 1A, B, and 4 were 97 to 100%. In treatment-experienced patients, given 12 weeks without ribavirin, the SVR12 in prior relapsers, 100%. And 16 to 18 weeks of therapy with ribavirin and prior non-responders with genotypes 1 and 4 and 6, 100%. We've seen that the efficacy was high regardless of the platelet count or FibroScan score. Grazoprevir and Elbasvir were well tolerated, and there was a similar efficacy profile in cirrhotics as non-cirrhotics with the same regimen. The package insert for the product in cirrhotics allows for 2 possible regimens: a 12-week regimen without riba and a 16-week regimen with it. The regimen does not depend on treatment naive versus experienced, or the absence or presence of cirrhosis. This is a very important point. The only driver of which regimen you use is the presence or absence of those baseline high fold change NS5A RABs, and we can identify 4 of them. The test is commercially available. We, and I'm sure my colleagues, and I certainly have ordered a number of these since it became available a number of months ago. It takes a couple of weeks, at least at the present time, in my experience, to get back. But usually while you're waiting for it, you're waiting for other things like information about fibrosis, prescriptions to go through. So we don't usually give these prescriptions immediately on meeting the patient the first time. There's other data to wait for. And we have now found this when we do resistance testing with whatever regimen we're contemplating to be a significant issue in terms of delaying anything that we want to do. Now, it's important to notice that the presence of these baseline RAVs is the determinant of which regimen to use in the 1As, not the 1Bs. So this is a 1A-based discussion when we talk about the RAVs. Now, as far as the AASLD IDSA guidelines are concerned with regard to this regimen in cirrhotics, for genotype 1A patients, the regimen for 12 weeks is recommended without riba if there are no RAVs, and 16 weeks with ribavirin if RAVs are present. We've already said that. And for the 1Bs, 12 weeks without ribavirin and no RAV testing is needed. The nuance in the AASLD IDSA guidelines, and the reason I have it on a separate slide, is that traditionally they have had boxes that are different for their, quote, alternative versus recommended regimens, or perhaps I should put that in reverse order. And I mean, clearly we have SVR rates of essentially 100% with the 16-week plus ribavirin regimen in the patients with RAVs. So one might ask why they designated this as an alternative regimen in both the cirrhotics and non-cirrhotics. And in the narrative, they're really not clear about that. It is pointed out in the general discussion that the number of patients with these high-level baseline RAVs was relatively small, but they don't explicitly state if that's why they categorize the regimen in this fashion. So now I'll talk about renal failure, and we all know that HCV accelerates mortality in advanced kidney disease, time to end-stage renal disease, and risk of renal failure even post-transplantation. We know about the problem with ribavirin in the setting of interferon-based therapy in this population in the past. We know that the major metabolite of sofosbuvir accumulates 20-fold in renal failure with potential side effects, although none recognized so far to my knowledge. And as a result of this, there's still no approved dose of sofosbuvir in patients with GFR less than 30 mils per minute. We did see some case series at the AASLD meeting a few months ago suggesting safety and efficacy for either the full or reduced, perhaps alternate day doses. But further studies are in progress, and there's still no recommended regimen in these patients with renal failure with sofosbuvir. The RUBY-1 study, of which our colleague Paul Pockros on the program with us was the principal investigator, with Elbasvir, paritaprevir / ritonavir, and dasabuvir, did suggest efficacy and safety, but the number of patients was relatively small at 20. Ribavirin was used in that study in the 1A patients, and there were frequent dose reductions or discontinuations of ribavirin. There is a study in progress, I'm not aware of any results, looking at ribavirin-free regimens even in the 1A patients. We do know, as Andy alluded to earlier, that the clearance of the two drugs we're discussing today, grazoprevir and Elbasvir, are not affected in renal insufficiency. So now we'll look at another study presented at AASLD by David Roth from Miami called the Sea-Surfer study, really a unique study so far of this regimen in patients with grade 4 or 5 chronic kidney disease. This is the study design. There was a deferred treatment group enabling the investigators to evaluate safety data comparing active therapy to placebo recipients, a very important feature of this study. For the first 12 weeks of therapy, it was a randomized trial stratified by diabetes and hemodialysis status, which most of the patients were on, as you'll see. Again, a large study, 224 patients, and 11 patients underwent intensive PK studies. These were genotype 1 patients, both naive and experienced, CKD stage 4 or 5. As you can see, compensated cirrhosis was allowed. There's some information about the definitions of cirrhosis that I won't repeat, and the patients could not be co-infected. The demographics, the majority of the patients, a slim majority had 1A, nearly 50% though had 1B. The great majority were treatment naive. There were a few cirrhotics, and about a third were diabetic. Somewhat over 3/4 were on dialysis and or had stage 5 CKD. And the very impressive SVR data, both by full analysis and by modified full analysis, leaving out non-virologic failures analogous to what we saw in the cirrhosis analysis before, are shown on this slide, with the modified full analysis showing an SVR rate in the immediate treatment group of 99%, 98% in the deferred treatment group that later went on to get therapy. Very large study, as you can see, involving a total of over 200 patients who ended up being actively treated either immediately or on a deferred basis. No real safety signals here, especially when you compare the incidence of various adverse events in the active treatment group compared to placebo, same number of SAEs, very few discontinuations due to AEs, only 4 deaths, and 3 of them, unfortunately, in the placebo patients. Laboratory safety, really no major signals, no ALT elevations to more than 5 times baseline, only 1 to 2.5 to 5 times baseline, and essentially no major bilirubin elevations either. And if you look at the hemoglobin data, again, this is in the absence of ribavirin, even in the genotype 1A patients, worth emphasizing again. If you compare the placebo bars to the active treatment bars, there really doesn't seem to be any independent effect of this regimen on hemoglobin levels, consistent with data from the rest of the program. So once daily therapy for 12 weeks was highly effective for treatment of genotype 1 patients amongst those with CKD stage 4 or 5, but mostly 5, it's worth emphasizing. Efficacy was consistent in the 1As and Bs, diabetics, and the patients on hemodialysis. Only 3 patients relapsed, and again, once daily therapy for 12 weeks was well tolerated in this study population, despite their advanced kidney disease. So here we have the AASLD IDSA guidelines, and even though we are focusing on one particular regimen today, I thought here, since this is a novel indication for antiviral therapy so far in the history of the field, aside from PEG-RIBA itself, I thought in the interest of being fair and balanced, we should mention the full recommendations in the AASLD IDSA guidelines, which tell us that for genotypes 1A, 1B, or 4, for patients for whom the urgency to treat is high and renal transplant is not an immediate option, 12 weeks of grazoprevir, Elbasvir. Genotype 1B, not 1A though, with the same proviso, the 3D regimen without ribavirin, and for 2, 3, 5, and 6, they recommend PEG-RIBA with a low dose of riba, as you see, and as a quote alternative regimen in the 1As, they recommend the 3D regimen plus ribavirin at a low dose of 200 TID to daily for renal failure patients. I think it is fair to point out again that the 3D recommendations are based, so far at least, on much smaller numbers of patients than were in the C-SURFER study. So we can ask some challenging questions in end-stage renal patients. Should all patients on dialysis be treated? Well, it seems logical now that we have an approved regimen with this kind of record to treat all non-transplant candidates. I think the thornier issue is in the transplant candidates, and here we have to ask a couple of questions. Should treatment of dialysis patients be deferred until after transplantation of HCV-positive kidneys, given the fact that these patients in many areas can get access to a donor kidney much, much more quickly? It can be weeks instead of years than their non-HCV infected counterparts. And should you just take your chances and hope to have successful antiviral therapy afterward? This is a very prevalent question nowadays. Should we transplant? And this is very controversial and certainly not standard at this time, but people are beginning to at least think about it and even do it, I'm sure under protocols. Should we transplant HCV-positive kidneys into HCV-negative donors? I'm sure that should be recipients, and treat afterward. This is really a dicey issue for obvious reasons. It goes against the traditional grain, but if we hypothesize that antiviral therapy of this nature is almost uniformly effective, and this is a way to get patients off dialysis years sooner, it may be the right thing to do. Now, we have one small study from AASLD that I'm not going to show today, suggesting indeed a high level of efficacy of antiviral therapy after renal transplants, just as we've become accustomed to seeing in the liver transplant patients. But we clearly do need more data on this question, and I'm just trying to be a little provocative and light a spark by raising these difficult questions. So now we come to the question portion, and I'll be happy to turn the podium, so to speak, back over to Paul.
Thank you very much, Ira. That was an excellent presentation and finished with provocative questions. So if you have questions for Dr. Muir or Dr. Jacobson, please enter them into your chat box on the right-hand, bottom of the right-hand column. And someone already has entered a question. I think before I present the question that's in our slide deck, it's a good question. It was straightforward. Why why would I pick Zepatier over Harvoni in genotype 1A patients? So I'll ask you both to take a minute or two to answer that with specific attention to patients who aren't able to reduce PPIs, end-stage renal patients, as Ira just talked about, and retail costs. So, Andrew, you want to go first?
You want me to ignore those things or include
No,
them?
I want you to address them.
Okay, because I do think that, as we all know in practice, we don't always get to pick, right? So some of it is, are you comfortable with a regimen, if a payer is telling you what you have to go with. So I think this is definitely a time you can feel great about this regimen, but however you're going to use it. I do think, those patients where we do worry that, we don't understand how bad the reflex is, or they tell us it is bad, they're requiring those high-dose PPIs, they're popping those antacids, then I think this takes the pressure off that, and you can feel very good about it. I really like this for the patients with chronic kidney disease, and obviously that's an issue for the patients with a GFR less than 30 mils per minute for sofosbuvir. So I think that's a clear advantage there. And the rest of the patients, I think it's a bit of a mix, and you can feel good based upon what your payer tells you.
Ira?
Yeah, well, I agree. I do take the PPI question seriously. We did see a little bit of a signal in one of the real-world studies presented at AASLD of about a 5% decrement in efficacy of Elbasvir-grazoprevir in patients on PPIs. We didn't have information from that database about how much PPI they were taking. We don't know how many were taking more than the recommended equivalent of 20 milligrams of omeprazole, but the PK data are there and do suggest decreased absorption with strong acid suppression. So for me, this has been a real issue, and I think would very well likely be a driver of decision-making in my practice. I think the renal comments also of Andy, I would echo. I mean, this is the regimen for which we have very robust information. I'm fascinated by the question of why in the C-surface study the 1A patients seemingly didn't need ribavirin. We haven't seen resistance analyses from that study to my knowledge, but with 200 patients in both of the active treatment arms, I assume there must have been a number of them that would be amenable to an interesting analysis. And maybe you don't need ribavirin to overcome the RAVs, as ribavirin seems to work in other settings in the DAA world, or at least that's the consensus that's emerging. I haven't gotten an answer yet as to what it is about renal patients that should make them not need ribavirin. The Ruby-2 study will be interesting in this regard. I think the big question in general, Paul, is the whole issue of RAV testing, whether it's cumbersome or whether it's just a way to more precisely pinpoint exactly what regimen your patients need. I don't find it particularly cumbersome. As I mentioned, the 2-week delay to get the results fits in with the timeline with which I institute therapy anyway. But of course, the other regimen to which you referred is an excellent regimen, and in some patients, though not all, doesn't seem to depend in terms of its efficacy on the presence or absence of RAV. So clinicians have to make their choice.
And second question from the attendees regards cost. The question is, it states, I don't know if this is true or not, that the average retail cost of wholesale, it says retail on the question, average retail cost of Zepatier is half that of Harvoni. Does this obviously the unspoken is it clearly influences payers, but should this and does this influence your decision for choice of drug? And we'll start with Andrew.
Well, I really try to take the perspective of my patient, so it depends on what their copay is and what their payer says and things like that. I'm glad to see the prices coming down. I'm glad to see the healthy competition, but it doesn't influence my specific choice for that regimen, for that patient.
Ira?
Yeah, I don't think about cost at all until a carrier tells me that I have to think about it. Now, you mentioned the lower retail price with this, as I believe is the case, but of course the whole issue of what the real costs that people end up paying are is shrouded in mystery to the public and, frankly, to me. and I think many other providers, because we all know that negotiated rates end up being what gets paid. So that said, I just don't know anything about the negotiated rates of one regimen versus another nowadays. But if a carrier came to me and said that they are concerned about cost and prefer that I use one regimen over another, given the essential equivalence of these regimens in terms of efficacy, I might not fight that as vigorously as I might have in the old days. That's all I can say.
Thank you. And there's now commercially available laboratory tests from LabCorp, I believe, that is automatically defaults for genotype 1A genotyping to NS5A testing. It provides the genotype, viral load, and NS5A RAV testing in all-in-one test. Are either of you using this test now?
No, and I appreciate you telling me about it. I actually didn't know that was the case. So maybe I'll start to do that.
Yeah, we have our own genotypes in-house, but I have been using the commercially available resistance testing to guide care. So.
Okay. Well, why don't we go ahead and do the case. It's on the slide deck. A patient with hepatitis C and end-stage renal disease. This is a 56-year-old black male, CKD5 on hemodialysis, genotype 1A, treatment naive, and a FibroScan score was done of 14.6 kilopascal. So you notice I don't use other non-invasive markers such as FibroSure or FibroSpect in an end-stage end-stage renal disease patient because these are not as accurate. He has well-controlled AODM and hypertension, body mass index 32. His kidney transplant team wants his HCV cured. So he's awaiting kidney transplant, but he's nowhere near high on the list, so it's not pressing. His baseline hemoglobin is 11, platelets 146,000. His HCV RNA is 5.6 million IUs, ALT 125, AST 130, bilirubin 1.1, albumin 3 grams, INR 1.0. So, Ira, you just covered this topic, so why don't we start with you? What are your treatment options for this patient, and which one would you select?
So maybe we can go back just for the audience as well as me to the first slide that shows most of the patient's characteristics, and then the next slide.
Okay, there's the characteristics, and there's the baseline.
So this patient falls into the population of patients studied in C-SURFR. It did allow cirrhotics into the study, and there were only a small number of them, but based on the collective experience with this regimen in the larger cirrhotic integrated analysis, as well as those in C-SURFR, I would see no reason not to have the same preference for grazoprevir Elbasvir without ribavirin in this population, just because he's cirrhotic. In other words, doesn't change my mind. I think he falls into the group of patients for whom this has emerged as a major attractive alternative. Really not alternative, an attractive option that we haven't had available before in the market for these renal failure patients. Now, the other option would be the paritaprevir Elbasvir-grazoprevir regimen, but at least at the present time, because he's genotype 1A, you'd have to use ribavirin. And again, that's based on a much smaller data set, and I would prefer not to use ribavirin whenever I can avoid it.
Okay, and Andrew, the recommendation I was made is follows the guidelines, the AASLD IDSA guidelines, but it does not follow the Zepatier label exactly.
Right.
Does that cause you any pause? How do you feel about that?
Yeah, I mean, I think that was one of the bit of the surprises in the package insert, and I'm personally very comfortable with the AASLD IDSA guidance. I feel very good about the fact that the C-SURFR study was well done. It's a robust study. We're not talking about a small sample size there. There also is a history, if you will, of patients on dialysis with our previous therapies doing quite well. And so I translate that a little bit. Their viral loads are a little bit lower. I actually felt like the 5.6 million here was kind of high. for what I'm used to seeing in some of the patients who are on dialysis. And so I'm willing to translate that experience of the past plus what we see in C-SURFR, along with my own discomfort with giving ribavirin to a patient who is on dialysis. I'm not a fan of it. I do think you can do it with close monitoring, with a very engaged dialysis unit, but you're taking risks, and many of these patients have underlying heart disease, and if I'm thinking about a potentially a few percentage point drop in cure versus the risk and what I think might be a great option to cure, I'm very comfortable proceeding without ribavirin here.
Great. And Ira, let's say the nephrologist calls you up and says, well, that's fine. I'm doing dialysis on this individual 3 times a week. We check his hemoglobin, his labs. So do you mind if I treat him myself? How do you address that?
I would try to gently probe what the motivation is. Maybe he's trying to get some practice. I would vigorously offer my services as a consultant who can be seeing the patient on occasion in between visits to the nephrology colleague. If he insisted, I would remind him about the ALT proviso in the package insert, the 8-week ALT check, because he might not be aware of that. I don't readily envision any of my nephrology colleagues taking this position in any absolute sense, but it's an interesting question. I'll grant you that.
Well, there are dialysis centers that I think are going to try to take this on themselves, but they probably rely upon the hepatologist they refer to sort out which patient they can safely take on themselves and which one they shouldn't. This patient has cirrhosis, so I agree with you. This one would be not one they should start with. That would be a long reach. Andrew, you work with closely with nephrologists at Duke, I assume. Would you feel comfortable letting them treat on their own? Let's say somebody with not like this, with someone without cirrhosis that had good counts and looked straightforward, treatment naive. Let's say they were genotype 1B, so there's no question they could use either regimen without ribavirin.
Well, I think, Paul, in general, I'm in favor of expanding the treaters in a variety of disciplines, as long as they go through the training and have access to somebody who's going to guide them through it. So I'm not personally averse to that, but it really would need to be with that significant training and some kind of mentoring relationship so they could reach out to you. But you're right, here with cirrhosis, and particularly in the discussion about ultimately for transplant, that's a separate issue here.
So there's another question from our audience. For the rare treatment failure following Elbasvir-grazoprevir, what is the next DAA regimen? Andrew, you want to take that first?
Well, I think we have a variety of failures from these other regimens, and this is where we will need to look at our resistance testing and try to determine it. And I think this is another area where we don't have the obvious choices, and I think we'll learn more at our upcoming meetings about what we can do. We've seen a variety of strategies, including extending durations, obviously making sure that you're going against your resistance profiling, but these regimens together, extended durations with ribavirin, those general strategies appear to be working.
And so, Ira, for the same, to extend that question a little bit, let's say you have some Harvoni failures, you've NS5A tested them, they have one of the or more of the mutations that confer resistance, the 28, 30, 31, or 93. Would you use Elbasvir-grazoprevir, with or without ribavirin, give that a shot, or would you wait for something else, or what?
Well, we know that patients who failed the Elbasvir-sofosbuvir with emergent NS5A resistant variants can succeed with retreatment, indeed in a majority of cases, though not an overwhelming majority of cases, by giving another course of therapy for a longer time. even without ribavirin, though I would agree with Andy's implication, I believe, that I would add ribavirin. I would throw the kitchen sink at any prior DAA failure, both in terms of giving as long a duration of therapy as I could, at least with the available regimens, and add ribavirin. Now, of course, at our center, we would try to get a patient like this into a clinical trial. I think we're all working on certain triple regimens that incorporate advanced members of the protease as well as NS5A classes with a nucleotide, whether sofosbuvir or another new one that's being studied by a different company. And of course, there was some recent data on the 3D regimen plus sofosbuvir looking pretty good in prior DAA failures. I don't know if that's practically accessible in the real world. So for now, we're trying to hang in there or put these patients in trials rather than treating them with the same thing for a longer time. I have not done that yet. Paul, may I make just one point? I see we're coming up near the end. Please. I may have said something during my talk that suggested that based on the data from the integrated cirrhosis analysis that there's something different about the regimens for prior relapsers versus non-responders, and I didn't mean to say that. I was just suggesting that biologically there may be something about the relapsers that's a little different. But the regimen choice is driven by those RAVs, again, not by the prior treatment failure modality, if you will.
Well, thank you for that clarification. And Vicki, I'll turn this back over for you to wrap up.
All right. Thank you very much, Dr. Muir, Dr. Jacobson, Dr. Pockros. I want to remind everyone that this webinar will be on the AASLD website, probably early next week in the liver learning section. Please take a moment to complete the short webinar evaluation that we'll be sending out. And I thank all of you for joining us.
Thank you very much. Bye-bye.
Bye.
Thank you.